All right. So, welcome everybody. My name is Dr. Bajwa, Lovejeet Bajwa. I'm a PGY3 resident in the Diagnostic and Clinical Pathology program. So, I'm going to be presenting for Grand Rounds today. My presentation's based on my poster that I presented at Drive Days this year as well. I'll just be adding on to that and providing a bit more additional information. So, before I get started, I'll just give Dr. Solez a few minutes to provide an introduction as well. He has a bit more familiarity with the BAMF classification system than I do, so um, I'll let him speak now. Go ahead.
Okay, so I thought you might wonder why I would suggest that anybody study the lymphatics. It's such an ancient subject. And it all has to do with the way the BAMF classification began in 1991. It's a very civilized beginning. Before there was a classification, the best known person in the field was Bob Colvin at Harvard. And eventually, what happened is that when we created the BAMF classification, he was a part of it. He was the sixth author on the paper published in 1993, but he also had his own competing classification, CCTT. And gradually, the idea came about of merging the two. And it was a very civilized, gentlemanly, kind of enjoyable and fun process, whereas you might think that it could have been a quite unpleasant process. So it's always occurred to me that maybe because Bob Colvin so thoroughly embraced BAMF that he stopped talking about CCTT and became one of the strongest proponents, that the things he suggested early in that period, maybe we shouldn't um, arbitrarily forget about them if there's some good ideas there. And he wrote a very inspiring editorial in 2003, emphatically lymphatic, about the role of the lymphatics in transplant pathology. And then that came back again at the American Transplant Congress in 2022. There was a very odd presentation that said that if you looked at C4D staining, sometimes the lymphatics were positive, and sometimes the peritubular capillaries were positive. It's hard to tell the two apart, and so on. Well, as far as we can tell, that's absolutely false. From the beginning, for the first person who described C4D positivity, there's never been a suggestion that it can occur in the lymphatics ever. And so it's not kind of confusing, is this positivity in the lymphatics or in the capillaries? But yeah, there was excitement about that at the American Transplant Congress. The only thing ever published was never peer reviewed. It's a preprint. There's been no follow up. So anyway, that's what stimulated us to look further into the lymphatics. And I think what we found is what you would predict, that since from the beginning, no one had ever suggested that C4D would ever stain the lymphatics, that if you do dual staining for lymphatics and C4D, you don't ever find the two occurring together. Yeah, so that's a little bit of history. It all goes back to the very civilized and fun beginning of the BAMF classification, Bob Colvin's important role in it, and his eloquently written editorial on emphatically lymphatic. So that's where it all came from.
All right. Thank you, Dr. Solis.
Yeah.
Will be that article will be coming up in the presentation as well. So I'll get started now.
Yeah, we can see your presentation.
Okay, perfect. So we'll get started. So the presentation is called Looking to Lymphatics for respect to renal allograft biopsies. Some of this research was also conducted by Dr. Sridevi Koduru. She's just started her residency at the University of Saskatchewan, or will be starting on July 1st, as well as Dr. Tim Solez, who just spoke earlier. So I'd just like to declare for in respect of conflicts of interest, I do not have any conflicts, and I will not be discussing any off-label use of drugs or devices during this presentation. Now, an overview of the presentation. So I'll be starting off going, well, not so much in depth, but I'll be touching on a couple of key points of the Banff classification system and providing an overview for renal pathology. And then the second part of the presentation is research on the role of C4D and D240 staining in lymphatics in post-transplant renal allograft biopsies, which is the research that we'd conducted following that pre-publication paper that we'd read about the involvement of lymphatics and antibody-mediated rejection. And then the third part of the presentation will just be a review of literature delineating the role of lymphatics in renal transplant rejection. So what is the Banff classification system? So it's an international standard. Banff classification system's been recognized as a standard for evaluating kidney transplant biopsies. This classification system works and provides a framework for histologic assessment of those transplant tissues. And it was developed by the Banff Working Group, which is a collaborative input of multinational, multidisciplinary professionals working together on renal allograft pathology. And it's effectively become the gold standard for evaluation of diagnosis of kidney transplants worldwide. Like Dr. Solez had alluded to, so the precursor prior to the Banff classification becoming adopted, there was another classification system as well from the National Institutes of Health, the CCTT classification system. So this is the Collaborative Clinical Trials and Transplantation System, and it also aimed to standardize the diagnosis of acute renal allograft rejection. This system recognized the importance of vasculitis and the role it plays in the treatment response and graft survival. So the system classified rejection into three different types: tubulointerstitial, vascular, and humoral types. However, the CCTT system did not use grades of rejection like the Banff classification system does. So usually grades of rejection are graded between 1 and 3, and those were actually incorporated into the Banff classification system. And when the two systems merged in the revisions of the 1997 schema, basically the most useful parts of both systems were adopted. Now, the Banff Foundation for Transplant Pathology, their overall objectives are to lead development and dissemination of international Banff classification of transplant pathology and to facilitate multidisciplinary and collaborative research to enhance its scientific basis, clinical utility to improve the care of transplant patients. So, 5 key factors that their objectives are, facilitation of knowledge and generation and translation in transplant pathology, with the ultimate aim is to improve patient outcome. Maintaining the spirit of Banff being a multinational, multidisciplinary consensus group, fundraising, and then guidance and financial support for working group activities and Banff meeting activities as well. Now, the history of the Banff Foundation. So it was initially held in August 1991, and the impetus behind the meeting was the recent publication of the International Society of Heart and Lung Transplantation. They published a consensus classification for heart and lung transplant biopsy interpretation, and to develop similar consensus for renal transplant biopsy interpretation as well. So the schema built on previous research that was undertaken at Johns Hopkins University. I listed 2 papers here, which were noted in the reference guide for the Banff classification system, but there's a lot more publication that is built on since then, but these were 2 of the foundational papers. Now, the consensus group meets every 2 years to revise and expand the classification system. And since its initial beginnings, it has now been expanded to include the development of classifications of allograft pathology in liver, pancreas, composite tissue grafts, as well as contributing to advancements in heart and lung allograft pathology classification systems. Since its first definition in the international Banff classification system, diagnosis of antibody-mediated rejection is based on 3 criteria which partially overlap. So we have the histologic evidence of AMR activity and chronicity, evidence of antibody interaction with the donor endothelium, and serologic evidence of donor-specific antibodies. The definition of these 3 criteria has changed significantly over the past 2 decades. Now, so just quick history, again, just showing you that it was first introduced in 1991, and the first major update to the classification was 93. And the most recent version of the classification was published in 2022. 1997 was the year where where they merged the CCTT classification system into the BAF system as well. I don't want to spend too much time here. This is it's just an overview of the key themes that have been involved in the BAF meetings since 91 till 2011. And it just provides you an overview of how the system has developed over time. Now, part of the math classification, they do have a diagnostic workup of biopsies as well, and part of this part of the diagnostic workup includes that specific criteria like specimen adequacy criteria must be met, as well as C4D staining should be performed via immunofluorescence on fresh frozen or via or IHC on formalin fixed paraffin embedded tissues. The block should be cut in several numbered level sections and examined with a H&E, periodic acid shift, and trichrome or elastic and Jones or methylamine silver stains. Now, the IHC staining for simian virus, the SC40 cross-reacting with BK virus should be performed when indicated, and where available, minute portions of the cortex should be embedded for electron microscopy as well. Now, depending on the clinical and histopathological findings, a complete nephropathological workup, including staining for immunoglobulin heavy and light chains and complement split products, might be necessary to rule out or confirm a diagnosis of glomerulonephritis. As well, other ancillary staining might be necessary as for native kidney biopsies to establish specific recurrent or de novo kidney diseases, such as Congo red. And testing for donor-specific antibodies via anti-HLA or other specificity should be done following the STAR guidelines, the sensitization and transplantation assessment of risk guidelines. So detection of non-HLA antibodies, including ABO antibodies and ABO incompatible transplantation, can be used if testing protocols are sufficiently standardized and clinically validated for the appropriate clinical context. At present, there's no non-HLA antibodies apart from ABO antibodies that have been validated sufficiently for inclusion into the routine classification system for kidney transplant biopsies. Ancillary molecular tests based on tissue and body fluids are also emerging. And pre-implantation biopsies should be obtained, processed, and reported as described by the BAF working group on pre-implantation biopsy. So that's a separate system. Key component of the BAF system is the BAF lesion scores. So the BAF lesion scores assess the presence and the degree of histopathological changes in the different compartments of renal transplant biopsies, focusing primarily but not exclusively on the diagnostic features seen in rejection. A caveat is that these lesion scores alone are not sufficient for various BAF diagnostic categories, and additional diagnostic parameters might be required, such as histopathological, molecular, serological, and/or clinical history. So these are the BAF lesion scoring categories. So you can see there's quite a few on the second page as well. Interstitial inflammation, tubulitis, intimal arteritis, glomerulitis, peritubular capillaritis, C4D, interstitial fibrosis, tubular atrophy, vascular fibrous intimal thickening, glomerular basement membrane double contours, and then mesangial matrix expansion, as well as arteriolar hyalinosis, hyaline arteriolar thickening, and total inflammation, inflammation in area of interstitial fibrosis and tubular atrophy, and tubulitis in areas of interstitial fibrosis. And then polyoma virus load is also assessed. I'll be going into detail on the two categories that were most relevant to the research that we completed. So the BAF lesion score on peritubular capillaritis and the BAF lesion score on C4D. The lesion score for PTCs or peritubular capillaritis. So PTC score of 0 means that the maximum number of leukocytes is less than 3. A PTC score of 1 means that there's at least one leukocyte cell in greater than 10% of the cortical peritubular capillaries, with 3 to 4 leukocytes in the most severely involved PTC. And a PTC score of 2 means that at least one leukocyte is present in greater than 10% of the cortical PTCs, with 5 to 10 leukocytes in the most severely involved PTC. And then the PTC score grade 3 is at least one leukocyte involved in greater than 10% of the cortical PTCs, with greater than 10 leukocytes in the most severely involved PTC. So it's the most severely involved peritubular capillary that really has an impact in terms of the grading. Once it's been established that there are leukocytes present in the cortical PTCs. Now, peritubular capillaries are by definition found in the cortex. Their medullary equivalent are medullary vasorecta, and peritubular capillarites constitutes microvascular inflammation as a feature of active antibody-mediated rejection or chronic active antibody-mediated rejection. So peritubular capillaritis can be observed with pure acute T-cell mediated rejection or borderline cases as well. Now, the number of luminal inflammatory cells includes polymorphonuclear and mononuclear leukocytes, with an asterisk used to indicate the presence of only mononuclear cells and the absence of neutrophils. The extent of the PTC inflammation of the biopsy should be documented as either being focal, which means that's 10 to 50% of the cortical area is involved, or diffuse if it's greater than 50% of the cortical area. However, the extent of inflammation does not contribute to the score, and the presence of associated PTC dilatation may also be noted. So, and then in areas affected by acute pyelonephritis or necrosis and subcapsular cortex with non-specific inflammation should not be scored. So you should exclude those areas when you're assessing them. And inflammatory cells with PTCs must be distinguished from interstitial inflammation by careful examination of the basement membrane stains as well. So PAS and your silver methenamine. And inflammatory cells with veins and medullary capillaries, the vasorecta should not be scored. So the assessment of peritubular capillaritis and the Banff lesion score for PTC can only be completed after exclusion of those areas, the pyelonephritis and infarcted areas, and exclusion of areas close to lymphoid aggregates to avoid confusion with lymphatic vessels. In addition, the Banff lesion score should not be based on longitudinally cut PTCs. Peritubular capillaries in areas affected by tubular atrophy and interstitial fibrosis must be explicitly considered for this Banff lesion score, so you don't exclude those areas. I have an image here, just providing some background on or some visual correlation to what we discussed, like in terms of the Banff lesion score for PTC1. That's a mild peritubular capillaritis we can see on the left hand of the screen. As we said before, at least one cell in greater than 10% of the cortical PTCs, one leukocyte, where those short arrows are. And then with
Phase
3 to 4.
2.
Pardon? Oh, sorry. So with 3 to 4 in the most severely involved PTC, which is longer here, you can see there's leukocytes right there. And then on the right-hand side of the screen is a Banff lesion score PTC2. And here it's moderate peritubular capillaritis defined as, again, at least one cell and greater than 10% of those cortical PTCs. So you can see with the short arrow, and then 5 to 10 leukocytes in the most severely involved PTC, which you can see here with the long arrow. The Banff lesion score for PTC3 is severe peritubular capillaritis. So in this case, we still need that one leukocyte being present in more than 10% of the cortical PTCs, but you should have greater than 10 leukocytes in the most severely involved PTC, which we can see here. And the image on the right hand of the screen is not a Banff lesional score. This is in terms of when you've longitudinally cut a peritubular capillary. So the short arrow shows that the peritubular capillary has been cut longitudinally, and it contains 4 mononuclear cells, but it should be disregarded for scoring. However, the neighboring peritubular capillary with the long arrow is cut orthogonally and would qualify for at least a Banff lesion score of PTC1, provided that at least there's one leukocyte in 10% of the PTCs overall. Now, the Banff lesion score for C4D, again, this is it's categorized into 4 different stages. So C4D0, there's no staining of PTCs and medullary vasorecta. With a score of C4D1, there's minimal C4D staining, which is greater than 0, but less than 10% of the PTCs in the medullary vasorecta. And C4D2, there's focal C4D staining, 10 to 50% of PTCs and medullary vasorecta. And then C4D3, there's diffuse C4D staining with greater than 50% of the PTCs and medullary vasorecta involved. So the score evaluates the extent of staining for C4D on endothelial cells of PTCs and medullary vasorecta by immunofluorescence on snap frozen sections of fresh tissue, or via IHC on formalin fixed and paraffin embedded tissue. Although areas of tubular atrophy and interstitial fibrosis have reduced PTC density, that could affect the extent of staining. The scoring of C4D in those cortical areas is not excluded, so you still include those areas when you're making assessment for the score. Now, scoring for the C4D staining is based on the percentage of peritubular capillaries and vasorecta that have a linear circumferential staining pattern. The minimal sample for evaluation is 5 high-power fields of cortex and or medulla without scarring or infarction. C4D must not be scored in areas of infarction. And then on immunofluorescence, staining should be at least 1+ in intensity. Strong staining is not required for a positive reading for IHC. In terms of extensive staining with immunofluorescence, the Banff lesion score of C4D greater than 2 is considered positive and a criterion for antibody interaction with tissue and is equivalent to donor-specific antibodies being present. Whereas with IHC, the Banff lesion score C4D greater than 1 is counted as positive already. This image is just showing you the differences, immunoperoxidase staining on the left and immunofluorescence on the right for C4D. The Banff diagnostic categories. So again, it's broken down into 5 categories. The first one being a normal biopsy or non-specific changes. And that requires you to exclude a diagnosis of categories 2 to 4. And then category 2 is your antibody-mediated rejection and microvascular inflammation or injury. And for this, you have 3 criteria that must be met for diagnosis. And active lesions of antibody-mediated rejection must be present in at least one of the following. Microvascular inflammation with a glomerulitis, a score of greater than 1, and or a PTC score greater than 0. And in the absence of recurrent or de novo glomerulonephritis, although in the presence of acute T-cell mediated rejection, borderline infiltrate, or infection, PTC score of greater than 1 alone is not sufficient, and you should have a glomerulitis score of greater than 1 as well. You should also have intimal or transmural arteritis with a score greater than 0. Or acute thrombotic microangiopathy in the absence of any other cause. So you need one of those factors in this category. And then at least one more of the following: linear C4D staining in peritubular capillaries or medullary vasorecta, C4D2 or C4D3 by IF, by immunofluorescence on frozen sections, or C4D score greater than 0 on IHC on the paraffin sections. There should be at least moderate microvascular inflammation. So your combined score of glomerulitis and peritubular capillaritis should be greater than 2 in the absence of recurrent or de novo glomerulonephritis, although in the presence of acute T-cell mediated rejection, borderline infiltrate or infection, PTC score greater than 2 alone is not sufficient. And again, the glomerulitis score must be greater than 1. Now the biopsy-based transcript diagnostics for antibody-mediated rejection or microvascular inflammation above a defined threshold, if thoroughly validated for use as a substitute for MVI and are available. So if that's been performed within your institution, I guess that could be done as well. Evidence of circulating donor-specific antibodies, so DSA to HLA or other antigens. If thorough testing for DSA has not yet been performed, this should be done following the STAR guidelines, and detection of non-HLA antibodies, including ABO antibodies and ABO incompatible transplantation, can be used as a serologic BAF criterion for diagnosis of AMR. If testing protocols, again, are sufficiently standardized and clinically validated in that clinical context. And C4D staining is noted above in criterion 2 may be used as a substitute for donor-specific antibodies. Chronic active antibody-mediated rejection has 3 criteria that must be met for diagnosis, and there should be chronic lesions of antibody-mediated rejection present, at least one of the following. So a transplant glomerulopathy with a CG score of greater than 0, and that the CG is for glomerular basement membrane double contours. If no evidence of chronic or thrombotic microangiopathy or chronic recurrent de novo glomerulonephritis, includes changes evident by electron microscopy alone. And then severe peritubular capillary basement membrane multilayering, that requires an electron microscopy for that diagnosis. And then 2 and 3 are identical to criterion 2 for active AMR, including strong recommendation for DSA screening whenever criteria 1 or 2 are met. Other lesions can be observed in AMR strengthening a diagnosis, but are not diagnostic in themselves. So if you have a arterial intimal fibrosis of new onset, excluding other causes, leukocytes within the sclerotic intima favor chronic AMR if there's no prior history of a T cell mediated rejection. And so for chronic AMR, I guess this is not active. All three criteria must be met for diagnosis with a CG score or greater than 0, and or severe PTC ML, which again is the peritubular capillary membrane, base membrane is multilayered. Absence of criterion 2 is defined for active and chronic AMR as above, and the prior documented diagnosis of active or chronic active antibody-mediated rejection, and or documented prior post-transplant or current evidence of donor-specific antibodies. And then your C4D staining without evidence of rejection. All four features must be met for the diagnosis. So you have to have the linear C4D staining, peritubular capillaries. Criterion 1 for active or chronic active antibody-mediated rejection has not been met. And negative biopsy transcripts, diagnostics for antibody-mediated rejection or microvascular inflammation, as in criterion 2 for active and chronic active AMR. No acute or chronic T-cell mediated rejection or borderline changes. Microvascular inflammation, that's a donor-specific antibody negative and C4D negative. In this category, and you must have at least moderate microvascular inflammation. That's a combined GMPTC score greater than 2. The absence of recurrent or de novo glomerulonephritis, although in the presence of acute TCL mediated rejection, borderline infiltrate, or infection, that PTC score again of greater than 2 alone is not sufficient. You must have that score of greater than 1 or equal to 1 for glomerulitis. Now, no linear C4D staining in peritubular capillaries, and there's no serologic evidence of circulating donor-specific antibodies as well, because otherwise they would be C4D positive or DSA positive. Now, probable antibody-mediated rejection has 4 criteria as well. The first one's identical criterion 1 for active AMR, and the second one is criterion 1 for chronic active and chronic antibody-mediated rejection are not met. And then absence of criterion 2 defined for active and chronic active AMR above as well. And then the fourth criteria is identical to criterion 3 for active AMR, but C4D must be negative. And now there's also C4D staining with acute tubular injury. And for this to be present, you have to have tubular injury, linear C4D staining in peritubular capillaries, as well as criterion 1 for active or chronic active antibody-mediated rejection has not been met. In clinical scenarios, there's early post-transplant in cross-match positive donor-specific antibody-sensitized patients that could result in a probable AMR. ABO incompatibility could result in accommodation, and DSA negative in conventional transplants it results in no AMR as well. So these are the last categories. I'll just name these off quickly because they don't really apply to the research we're going into, but category 3 is just suspicious borderline for acute T-cell mediated rejection. And category 4 is T-cell mediated rejection. Category 5 is your interstitial fibrosis and tubular atrophy. And category 6 is other changes not considered to be caused by acute or chronic rejection. So if you have your polyomavirus nephropathy, post-transplant lymphoproliferative disorder, calcineurin inhibitor toxicity, ATI, recurrent disease, or de novo glomerulopathy other than transplant glomerulopathy or pyelonephritis, drug-induced interstitial nephritis, those would all be falling into category 6. Now I'll just briefly go over our research. So the research that we did presented at Drivedays was based on this pre-publication paper here. And this study was conducted at the University College of London by Jaffrey and colleagues, and the use of three-dimensional imaging and RNA sequencing to assess post-transplant renal allograft biopsies is what they did here to implicate the perturbation of lymphatics and autoimmunity. So they used three-dimensional imaging and single-cell RNA sequencing to study lymphatics in the human kidney. Their study found a hierarchical arrangement of lymphatic vessels within human kidneys, initiating along a specialized nephron epithelium in the renal cortex. This epithelium displayed a distinct kidney-specific transcriptional profile. And with respect to chronic transplant rejection, they noted allograft lymphatic expansion alongside a loss of structural hierarchy, with human leukocyte antigen-expressing lymphatic vessels infiltrating the medulla, providing a target for alloreactive antibodies. Their use of RNA sequencing was able to reveal structural and transcriptional perturbations in rejecting kidney transplants. The authors noted the distortion of lymphatic architecture was reminiscent of blood endothelial disruption observed in chronic rejection, where donor-derived endothelial cells expressing MHC class II molecules, human leukocyte antigen HLA-DR, HLA-DQ, and HLA-DP are targeted by alloantibodies. The assessment of lymphatics for MHC class II expression revealed HLA-DP and HLA-DR transcripts with minimal HLA-DQ being detected. The authors also noted HLA-DRB5 expression was greater in kidneys with rejection than those with chronic kidney disease. Subsequently, the authors performed C4D staining of the specimens in their data set and found deposition on podovan positive lymphatic vessels in the cortex of transplant rejection tissues. The authors suggested that based on the findings from their data, allograft lymphatics may be directly targeted by donor-specific HLA antibodies, leading to complement activation and analogous mechanism that was described for blood vascular endothelium, potentially leading to distorted lymphatic architecture observed in rejecting allografts. And this is the kind of puzzling part of the study, because nobody had ever described this before. Like Dr. Solez said, that finding C4D staining in lymphatic vessels. And so that was what we went out to investigate, that maybe there was something that had been missed, or to just review their findings and see if they were in keeping with the past publications. Just providing a poster here. This is a copy of the poster I presented at Drive Days. I don't want to go over all of the details, but in particular, we completed a dual staining on 16 specimens to detect antibody-mediated rejection, based on that previous paper, to see if we would find C4D positivity within the lymphatics. We didn't find any dual staining that was appreciated in any of our cases. And we did do a thorough investigation. We met with the IHC technologist and spoke with them about the process involved, whether perhaps reversing the stains or if there's some type of loss of antigenicity due to the age of the specimens. But overall, we ruled out any of those other kind of analytical causes, and it appeared that that previous historical findings were in fact correct. The one note that we did find here was that one of our cases had a significant increased number of lymphatics present when we stained for D240, and so that's what led us to consider that the quantity of lymphatic vessels might be another area to focus on in terms of lymphatic vessel density and their role in transplant rejection. So again, our research findings were presented at the 2025 Drive Days conference, and with the absence of dual staining for C4D and D240. Like I said, one of our cases revealed a significantly high number of lymphatic vessels. There's 18 D240 positive structures in a 40x field for that specific case. And future research will be directed towards further investigating the changes in the number of lymphatic vessels and their utility in identifying unexplained microvascular inflammation in renal allograft biopsies. The role of lymphatics in renal allograft rejection has been identified by a number of research teams, and a review of those publications now follows. So this was the paper that Dr. Solez had referred to, the Emphatically Lymphatic by Dr. Colvin from Harvard University. And this was published in 2004. And so Dr. Colvin discussed the role of lymphatics, and in particular the application of lymphatic endothelial cell markers such as podoplanin, differentiating PDCs with associated inflammation from lymphatic vessels. He raised the issue of increased lymphatic density in nodular infiltrates and whether there was any associated clinical significance in transplant rejection. The next study we reviewed was the clinical pathological study of expression of lymphatic vessels in renal allograft biopsy after treatment for acute rejection. And so the authors in this study investigated the development of chronic renal allograft rejection in case where humoral immunity was not activated. The authors utilized D240 to distinguish between lymphatics and PTCs and assess the specimens for the presence of inflammation. The study found increased lymphatic vessel density to be associated with the presence of any inflammation in early post-transplant biopsies. Some of the same authors were involved in the second study, and this is a pathological analysis of lymphatic vessels in early renal allografts. So in this study, subsequent study, the authors investigated the role of lymphatics following an acute rejection episode. And the slides were restained with D240. And the study correlated lymphatic vessel density in post-transplant biopsies after an acute rejection episode with band scoring of those specimens. Increased lymphatic vessel density was found to correlate with increased band scores for a given biopsy. Yeah, this is the third paper that I reviewed. So missing self-induced activation of NK cells combines with non-complement fixing donor-specific antibodies to accelerate kidney transplant loss and chronic antibody-mediated rejection. Now, the authors of this study investigated the role of NK cells in the setting of a chronic antibody-mediated rejection. They noted that donor-specific antibodies binding need not always involve the activation of the classical complement cascade and can result in the activation of NK cells, which result in microvascular inflammation. Also, recipient NK cells can also trigger antibody-independent microvascular inflammation by sensing the absence of self, HLA class 1 molecules on allograft endothelial cells. And they completed a multivariate analysis that revealed that missing self or missing HLA class 1 molecules was an independent predictor for transplant failure following diagnosis of chronic antibody-mediated rejection. Subsequent investigations using co-cultures of human NK cells and endothelial cells confirmed that addition of missing cells to donor-specific antibodies induced NK cell activation and increased endothelial cell damage. Here's just an image from their paper, just explaining again, that they assessed the microvascular inflammation as using a BAS score of G plus PTC of greater than 2. And a positive presence of anti-HLA donor-specific antibodies was assessed, and whether there was a C3D binding for donor-specific antibodies or if there's missing self. And in the end, they were able to determine that missing self is associated with increased graft failure. So these are the resources that I referenced in my paper. The reference guide from the Bath Foundation, the American Society of Nephrology. I just refer to their websites, but then I have the articles and papers that I reviewed listed as well here. Next 3 pages. All right. Thank you so much. I'll stop sharing now.
Right. 20 minutes for discussion.
All right.
That's good.
So does anybody have any questions or?
That was a really good talk. I enjoyed it. I'm curious, do you have any ideas of why these lymphatics would be increased in this one case?
So based on our theories, like there has been a noted increased lymphatic density following post-transplant. Now that's a natural phenomenon that occurs, but it can also be seen as a result of rejection as well. We don't have a lot of data in terms of why that might be occurring. That's something that we're going to kind of look forward to in the future.
So you don't find lymphatics in the medulla normally, but in these situations you do, and you could think that that might wash out some of the osmotic gradients. So it would probably interfere with the concentrating ability if you have a lot of lymphatic flow into the medulla.
Lovejeet, I have a question as well. It's Rizwan here.
Sure.
For your study, so you did a dual podoplan D240 and a C4D IHC, is that correct?
Yeah, that's correct.
So they both sort of stain the cytoplasm. So how did you evaluate or differentiate if it's did you have different colors? Did you
Yeah, exactly.
but even if you have different colors, they stain the same location. So do you have a better example, other than the one on the posters, so that to sort of show how they would have looked like when they overlap versus not?
Well,
but they don't overlap.
Right.
They never overlap. Yeah.
But even if they did, what color would it show up? What color was the D240? What color was the
right.
C4D?
The colors were, we had the D240 was in brown, and our C4D staining was in pink. But the what we also did was because we weren't sure of that very similar situation, are we able to pick up on the color? Are we missing it because of the way that we're processing the two stains? So we did look at a selection of the slides with just one stain performed on each, just to confirm whether there's actual staining occurring or not. And we were able to do that. So we did have separate slides with C4D and D240 alone, and we compared them to the dual stain slides just to ensure that there was no loss of antigenicity, or that that we weren't having any like variations there that are spurious.
Okay, thank you.
Any other questions?
All right. Well, if there's no other questions, I guess I'll let everybody off a few minutes early.
Yeah, thank you for presenting today.
Sure, no problem at all.
And this is actually our last rounds for the academic year.
Wow.
So yeah, I hope everyone has a good summer, and we'll start up again in September.
Sounds great. Okay.
Bye,
Thank you,
everyone.
everybody. I appreciate it.
Yeah.
Thank you. Bye.